first bone that's lost is the facial incisal line angle.
Okay.
The most critical area for the loss, premaxilla. When we lose that facial incisal line angle, what happens? We end up having to place our implant more apically or more palatal. And that ends up with an implant tooth that looks like this next to a regular tooth that looks like this. So our strategy has to be either to take advantage of whatever facial incisal line angle there is, or compensate for that, or regenerate that. You get a better clinical outcome, a better aesthetic outcome. So now let's look at this ridge. It's less than ideal. What do we do here? We can place a more narrow implant to be within the confines of that bone. A lot of people do that. They're faced with a ridge that looks like this. You realize that you're going to have to use an implant that's smaller in diameter, so you want to maximize its length to compensate for that, right? We all do it every day. But suppose this is a molar position, and a small diameter implant is not going to be sufficient for that. What's the next thing we do? We do a ridge plasty, right? We cut down on the top of the ridge.
Yes.
Now we place a shorter, wider implant, right? We do it every day. That's what we do. But that's fine in the non-aesthetic zone. You can't do that in the premax zone. As opposed to placing an implant in its correct position, but now what do we have to do? Now we have to graft on the outside. We have to regenerate that missing part, which we call the facial incisal line angle. So all of our strategies in bone grafting, what we call the holy grail, the most important part of the bone complex in oral implantology is the facial incisal line angle, because that's the part that always gets into trouble. Periimplantitis almost always starts on the facial, right? Or aesthetic defects always start on the facial because of the missing facial incisal line. So here's a case where we're going to, it's a BW ridge, posterior mandible. I'm looking at the patient, I'm sitting on the side here, looking at the lower right side of the patient, just like the pictures I showed you before. Knife-edged ridge, BW, ramped ridge, 45-degree angle, one wall defect. I'm going to put my tenting screws in. But the key to this is to put the head of the tenting screw in the exact position where I want my facial incisal line angle to be. It's not just putting screws in here. They're strategically placed in that position. And you know they're 5 millimeters away because when my assistant takes her suction tip here, the suction tip is 5 millimeters. See, it goes under the screw. That's how far off those screws are. But they're angled up to the position. That's going to be my facial incisal line angle. This is a bone graft, PCP, with autologous serum, collagen membrane, which will hydrate with serum, then a final PRF membrane. There it is. We do a periosteal release, and I want primary closures in these cases. I don't want anything open. So we will get primary closure. There it is. Now let me talk a moment about suture. Never rely on interrupted sutures alone to close these flaps. How often do your patients return and you find interrupted sutures loose or gone at the surgical site? You see it every day, right? It's because interrupted sutures are not meant for flap closure, they're meant for flap alignment. The suture technique that you use is a mattress suture. Very, very famous clinician who died about 10 years ago. His name was Norman Crane. He headed the Brookdale Implant Institute, one of the big hospitals in New York. And he wrote one of the first major textbooks on implant dentistry. And he had the 10 commandments of implant surgery. You know what the number one commandment was?
Sutures.
Thou shalt use horizontal mattress sutures. And you know, way back when. So it was funny to see that so many years later. So here's a combination. Here's a couple of interrupted, and then some interrupted, then horizontal mattress sutures. The horizontal mattress sutures don't come out. the interrupted sutures do. So just use this, usually I'll do it at the papilla here, maybe I'll do it here, maybe one in the center, and the rest of it will be horizontal matches. And those flaps do not open. Now I'm gonna re-enter, and I'll wait 6 months in these cases, where there's a one wall defect with 5 millimeters or more of bone that have to regrow, I'll wait 6 months. But now you can see something amazing. Look at that bone regeneration. No particulate, 0, because that TCP resorbs 100%. And because it was a calcium-releasing bone graft material, and here's the original ridge right here. Now I've got a 12 millimeter wide ridge with good cortical bone. Watch the vascularity of this bone when I remove these screws.
So the screws it's as a guide for the bone?
Yes. Look at the vascularity where it's described. Now I'm going to put a 6 millimeter, this is a 6 millimeter drill with 3 millimeters of bone on either side. And when I remove the drill, look at the vascularity of this grafted site. I've got the highest percent, it cuts like D2 bone, it's amazing. Look at the bleeding from that grafted site. That is what I want to see. 75%. See, the implant is wet? It's wet because I dipped it in the bottom of the PRF box. We're going to show you how to do that tomorrow. We place this in position. Here's our first 6 millimeter wide implant. Then I place the second one more posterior. Let's put the bone on the other side of it now. And one more posterior here. There's our second one. And it reaches like that, anybody can place an implant in this. It's amazing. And there's the original ridge back here. All this is grafted and regenerated bone. 75% bone bone. This is what it looks like after I place my healing abutments placed. Look at the quality of that tissue. And this is a 1 year follow-up. I don't know, about 3 or 4 years. It still looks exactly the same, 3 or 4 years. But what you didn't see from these previous pictures is that this tooth and this tooth are also implants. And I'm going to show you the radiograph. This was, I didn't show the whole thing, but there's 2 implants here. See the bone here? This is extracted implant, but pretty decent quality of bone surrounding this implant. Look at the bones in between these 2 implants. And weren't we taught that grafted bone is of lower quality than post bone, vital bone? It's the opposite today. We can actually graft these sites and end up with better mineralization and better density in the grafted sites than post bone.
Can we go in for immediate loading at this particular time?
For sure. With this quality bone, absolutely. It's amazing, amazing stuff. You see that kind of mineralization. Cortical cells block grafts. They come from all different areas. I'm not going to make a big deal out of this because we need fewer and fewer of them. But we used to take block grafts from every possible area you can imagine, including areas where we should not have. We had some failures, and the more cortical in nature that they are, especially tori, don't use those. They're good if you put them in a bone mill and mix them up, but don't cut these into cortical cancellous bone blocks. They've got no medullary component to them. You don't. Most of the time today, we're using ramus block bone. We no longer go to synthesis. And I'm going to do a little bit of maxillofacial anatomy later on today, and you're going to see anatomy that you've never seen before, and why we don't do this anymore. Vertical ridge augmentation. Vertical ridge augmentation almost always requires a cortical cancellous block graft or a KHOURY bone plate if you can establish contact of the bone on either side of a defect. In other words, if it's a saddle defect, where the bone plate will sit on 2 sides of the saddle defect, and you can put your bone screws. But to try to put a bone plate like this, just hanging in space with 2 bone screws, that's really difficult to do. And I tend to want to use a cortical cancellous block graft when I do that. But here's an example, harvesting a block graft and transposing it to the site. Because then what I'm doing here is I'm also recreating what?
buccal.
my facial incisal lining. And a lot of times when we're doing these cortical cancellous block grafts, I'm deliberately going across the external oblique ridge to get that little turn, and I use that turn to create my ideal anatomy. And that's what it is, fully incorporated. So it looks like with the 2 bolt screws in place, and then drilling our osteotomies for our final implants. Again, just going through the case real quickly, and the implants in place bilaterally.
You are talking about this facial incisor. You are controlling the screw. You said about the angle
Yeah,
of the
let
screw.
me draw that for you. Let me show you what I meant by that, in case that wasn't clear. Here's your first defect. If you were to try to do a KHOURY bone plate in this case, which would look like this. You have to put 2 bone screws in. The bone screw would have to then look like this. You know how difficult it is keeping that bone plate in that position when you screw these things in? It's almost impossible. But if your defect, let me extend this out now. If your defect now look like this, I can rest the bone plate on either side of that defect, and it's an easy thing to get them to stay in place. Does that satisfy your question?
Yes.
So I'm looking at the site. I'm making a decision. If I don't have these ways on both sides to secure my plate, that's going to be a cortical cancellous block graft. If I have room on both sides to fix my plate, it's going to be a KHOURY bone plate.
Is it possible to create that kind of a contour and then fix a cortical plate?
When you say create the contour, you mean
Ridge.
can you? Yeah, I suppose you could in a particular case, but I let the case decide for me, because I've got all these different possibilities. I'll look at it on a cross-sectional, I look at a PATRX, I'll look at a cross-sectional CBCT, I'll look at what the critical structures are, I'll decide what length bone screws I can put in, then I'll decide whether it's going to be a block graft, whether it's going to be a KHOURY bone plate. That's what the doctoring part of this is. I spend more time in the decision-making process than I do in the physical manifestation of the surgery. I can spend 4 or 5 hours planning a case that might take me an hour, hour and a half to do. Because I agonize over that. I really look closely at these things. Look at all the different possibilities. I've done these with tenting screws, even vertical with tenting screws. Done every kind of thing you can imagine. It's all dependent on the site. That's why you need to have.
To get a good height, just the cortical, even if there was a good crater there, to get a good height, just the cortical bone won't be enough, right? I mean, how can you get?
When you say height, you have to tell me how much height. If you're using particulate alone, I would say 3 to 4 millimeters is the max you're going to get with particulate graft control because of scar contracture. That's why we end up with cortical cancellous block grafts or KHOURY bone plates, because it doesn't allow that tissue to retract and scar down over the top of that. You're not going to lose your volume. That's why I use the cortical bone plates here. Where volume is critical, you have to use something that's going to be there longer.
But if we don't have this edge, what's your opinion?
We
What
don't
do we have
have-
to do? Yes, this one.
This defect?
Yes. When we don't have-
Then cortical cancellous block graft, or titanium mesh, or yeah, something like that. And when we get to implant placement, I'll show you how we can use implants as fixation devices for mesh as well. Laterally positioned KHOURY bone plates. I use this more and more often now instead of cortical cancellous block grafts, and the reason for that is that I find that when bone is growing into a block graft, it only reaches a certain point, and the bone cells don't get into the last part of that, and then what happens over time is the outside of the block resorbs away. It doesn't become completely incorporated. With a KHOURY bone plate, where you can actually take a piece of bone, and just like doing a ridge split, except now you're intentionally separating your plate from the rest of the bone. And what I do here is I will actually put a spacer. I have little spacers that I use. And I use the spacer to keep the block out while I put the bone screws in. If I remove them, then I'll put my bone graft inside there. But you'll note that the screws are not parallel. They're more angled off like this. This way, the plate won't collapse inward. Put autologous bone inside there, and then place your material. Titanium mesh cases. Again, this lecture could be a full day. I can show you case after case. You know, in a day like this, there's a limitation of how many of these different cases that we can show you. I'm going to give you a taste of everything, and then if you feel that this is something that you want to learn more of, take a course in just mesh. Take a course in block grafting. Go to Dr. KHOURY's office in Germany, take his bone grafting course. There's so many things you can do. But here's a case where there was a missing right cuspid, and this is the typical kind of case we'll use titanium mesh for. It's bad enough that it looks like this, but you know, number one, the facial incisal line angle is gone. And two, whatever soft tissue defect you see, the bone is going to be that much worse underneath. It always looks worse when you open it. This is what it looks like. In this case, both the facial and palatal walls are missing, and because there's so much bone loss here, it's now stripped down the bone from the two adjacent teeth. Now, most people will be content just regenerating enough bone here to place an implant, but for me, I want to also think about regenerating the bone that has been stripped away from these two teeth. And one way we do that is we actually use titanium mesh. Note that the titanium mesh doesn't just cover the defect, it also goes out and away from the other natural teeth, and we graft under that as well. So we end up with something that looks like this. See the little bit of the screw showing through there, but look what happened. Look how we're able to regenerate the bone around these two teeth as well. That's the before, that's the after. So we're saving the other teeth as well. How many of you have used autologous dentin, taking extracted teeth and grinding them down to use that as a bone graft material? We do that in my practice. It's a great adjunct to this. I find now that, remember the case that I showed you, the grafted case where I placed implants, I did extraction, we did implant placement, but I had resorption of the facial plate. The way I prevent that today is to use an autologous dentin graft in the gap. Because the autologous dentin does not resorb. It's like using a xenograft, except that because it's not a foreign body, it's a natural material, you get a different quality of bone that surrounds the dentin particles. Completely different.
And crushing the teeth, I mean?
Yes, I'll show you what that looks like.
Like something like a socket shield. Is it what the
Socket shield is different. I will also show you some cases of socket shield, but I'm going to show you why we use dentin grafting. This is what it looks like. It's Cometa Bio is the name of the company. And this is what it looks like. There you have the little dentin particles, and look at the bone that's going around it. So you actually get a higher percentage of bone than you would using a xenograft. You get almost no soft tissue around it like you do with xenograft. And you don't see multinucleated giant cells, so there's no inflammatory reaction around it. So if you're looking for a non-resorbable material, there's nothing better than the patient's own teeth as a dentin graft. So we extract the teeth, we clean the teeth, we grind and sort them. We're left with this. I'm going to go through this quickly. What we do is we take out the teeth, The contraindications to this are the root canal tooth. We do not use root canal teeth because you can't debride the inside of those things. You can't clean it out. But if that's no root canal, we will remove any restoration that's present. I also remove the enamel, so we're just down the dent. Any restoration, any enamel, and then we just take the burr and we literally clean off any of the dentin that's exposed, cementing that's exposed, because that's where all the biofilm is. Down to good, solid, healthy dent. Then we put it into the grinder, we dry it off, that's what's left. Put it into the bio machine. We set it on grind first. We put the teeth right here. And then it only takes maybe a few seconds, like 20 seconds or so, depending what you set on. It actually grinds it down. Here are the teeth. And then what happens is, let me go back. There's two trays, the top one and the bottom one. Because after you grind them, you go back to the setting right here, and it says sort. And actually, almost like an ultrasonic, it vibrates, and the different particle sizes go into the different shelves. The very large ones go in the upper one, the very small ones go into the lower one. And that way, depending on the kind of defect you have, you use the larger or small particles. There it is. Look at that. Beautiful graft material. Then we have a series of cleansers that we use, a demineralizer, a cleanser, and then it doesn't have to be sterilized because we're using it, and then we're delivering this right to the defect area. We can also mix it with autologous fiber and make essentially sticky dentin bone. It works great. And here's a case I did just 2 or 3 weeks ago. I extracted a bunch of teeth. This is my bio. I've already mixed it with fibrin. That's why it's sticking together. And then I'm going to take this right into the gap. I'm going to take these larger particles. Now this is a special plugger I have. It's from Ufridi. It's actually a composite plugger. It's curved on the end, very narrow and curved, that goes down around the implant body into the gap. It's the perfect instrument for this. So we extracted 7 teeth and then put 8 implants in. Let's talk now about complications. Complications are a part of everything we do, regardless of your specialty. We have our skill set, we go through our training, we come out with a rationale for what we do. The problem is, number one, we don't have control over everything.
Yes.
2, there are certain limitations to what we do. 3, there are some things that we frankly just don't have any control over at all, which is things like patient compliance. You give a patient a list of instructions when they leave. You say don't smoke, and as they're getting into their car, out comes a cigarette and they're smoking already, right?
Within 1 hour.
So, and you tell them not to eat on that side or not use their appliance, and they forget. And for me, in my practice, the biggest offender is when I do a single tooth extraction, immediate implant, and immediate provisionalization. Very careful to take everything out of function. And I say, don't bite down on your front tooth. They go home. They call a few days later, Doc, my implant hurts. And they confess. They said, I completely forgot. I was feeling so good. I bit down on my front tooth. I heard a crack. Sure enough, they come in and the implant's gone because they fractured the bone. That's patient compliance. But we talk about potential complications. Let's look at these cases because I've experienced every one of these things through the years. And I don't want to say it's a learning curve. I hate that term. I think that term really sucks, actually. Learning curve. What it means is, because you don't know what you don't know, you're condemned to follow in the path of failure until you're wise enough not to fail, or not to do the right thing. So let's get a little bit of perspective here, and we'll talk about this. Tension on your flap at closure. Why is it important not to have too much tension on the flap at closure? The obvious, because it's pulling on the tissue. There's one thing that's less obvious. The more you stretch tissue, more you have vascular embarrassment. You ever take a rubber band, big thick rubber band, and hold it, and then pull it like this? What happens to the width?
Stretch.
Decreases, right? Same thing happens with blood vessels. So when you're stretching a flap, you're decreasing the volume of the blood vessel. That's called vascular embarrassment. Next, porous suture technique. If you're using only interrupted suture, expect to see outcomes like this. Interrupted sutures are not meant to close flaps, they're only meant to approximate flaps so that you're suturing them in the right position. Lack of vestibular depth. Another key component to periimplantitis. I will guarantee you, if you look at the majority of your periimplantitis cases, you take the lip or the cheek and you pull on it, you're going to see the gingival margin and the mucogingival junction moving every time you move your lip or your cheek. Lack of vestibular depth is one of the key components of developing periimplantitis. What do we do in those cases? Free gingival graft. And what do you do by the essence of free gingival graft? Doing a vestibuloplasty, right? Because you're apically repositioning your flap. So every one of these cases that I do, if there's lack of vestibular depth, doing a free gingival graft and a vestibuloplasty at the same time. They go hand in hand. Lack of keratinized tissue. What's the minimum amount of keratinized tissue you'd like around the tooth? 2 to 3 millimeters. You know what? I think that number's wrong. You know why I think it's wrong? Because you're only looking at it in terms of the amount of keratinized tissue. You're not looking at it in terms of whether or not it's attached to the bone. Keratinized tissue that is not attached to bone is no different than alveolar mucosa. And I'm going to show you some videos, I believe, today, that shows what happens when you pull on a cheek or a lip with narrow vestibular depth, and you can see the whole mucogingival junction and the free gingival marker moving, even though there's 3 millimeters of keratinized tissue. It's meaningless unless it's attached to bone. Another reason why we develop periimplantitis.
So maybe we have keratinized tissue without attaching to the bone? How can
Oh yeah, I'll show you that. Very simple. Very simple. You see it all the time. Overfill a defect. Okay, there's a limit to how much you can fill a defect. Look at this. And maintain flap closure, because you get vascular embarrassment if you do that. Highly movable flap area. See this frenum attachment right here? For the people in the laser world, what do? Do frenectomy, right? We do it pre-surgically, because if we try to do it at the time of surgery, it really makes healing a whole lot harder. Patients uncomfortable, they go crazy. Do a frenectomy first, then go back in. But more often than not, you'll find in some of my videos, I don't have enough time to show you everything that we have. It would take literally days for me to go through this. But if I'm going to do a critical area, either bone graft or an implant placement, and I find that it's insufficient keratinized tissue or insufficient vestibular depth, I will do the free gingival graft and the vestibuloplasty first. It only takes 6 to 8 weeks to heal. Then go back in and have fun. And your success rates go up dramatically when you do that. You try it the other way around, you're not going to have that degree of success. Frenum pull, right here. Trauma for an appliance. What are they going to wear over this when they're done? You're going to wear an appliance that sits on the tissue? Forget it. It's always going to open up. Necrosis of flap. How do you get necrosis of the flap? Well, you get vascular embarrassment from getting crazy with your suturing technique. If your tissue's blanching when you're suturing, you don't expect to get anastomosis of your flap margins. Failure of graft turnover. Why would graft fail to turn over? Forget the fact that you've used biologics. Let's assume that you're not going to use a xenograft. Why wouldn't you get bone graft turnover?
No blood supply.
No blood supply. So why would there be no blood supply? What would occur in that case? Well, number one, it's a heel defect that's all cortical bone. Example, posterior mandible. If you don't decorticate that bone, you can put all the bone graft you want on there, nothing will ever heal. Second, Second most common. You ever extract a tooth and look down inside and say, okay, bleed? And a minute later you look down and you say, okay, bleed. And a few minutes later you realize, this is not gonna bleed. Why? What is it bleed? What happened there? And what's the reason for it? What area is most likely to look like that?
Anterior.
No.
What happens when we do a root canal on the tooth?
You cut the,
We're removing the pulpal tissue. Does the pulpal tissue anastomose in any way with other tissue?
Yeah.
You ever hear of dental tubules?
Yeah.
Yeah, sure.
There's direct communication between the pulpal tissue and the PDL. When you remove the pulpal tissue, the dental tubules dry out, the PDL atrophies, and what do we get in that tooth? Ankylosis. What is ankylosis?
No PDL.
There's no PDL, but what happens to the bone? It becomes cortical in nature. There's no vascularity anymore because there's no stimulation from the PDL, because there's no stimulation from the pulp. So it's a vicious cycle that we go through. Root canal, atrophy, ankylosis. Then we have, because it's ankylosis, there's no more stress relief in function, we have a fracture of the tooth. Now we remove it, we look down, we see no bleeding. Why? Because the lamina dura around the tooth has become cortical bone. That's why. We put graft in that, we come back in 4 months, there'll be nothing but graft material. What do you need to do there? Then of course, poor patient compliance. Now, this was supposed to be the coffee break. So how far behind am I right now?
No, it's okay. No, this is for tomorrow. Because have a break with
Let's see. Well, my next, I guess, what time do you want to take lunch, though?
1 o'clock. So we have 45
Fine.
minutes.
Let me see if I can get through as much of this. When it comes time to lunch, where I am at that point, I'm gonna stop.
That's okay.
That's it, because I need to get on to the other things. All right. I have 45 minutes. Enhancing soft tissue and implants. Now, I'll go through this more quickly because I've already talked about some of these concepts already. And advanced soft tissue. I mean, everybody knows what a free gingival graft is. But we look at a free gingival graft like this. There are times when we'll do free gingival graft post-implant placement. There'll be times when we do it pre-implant placement. If I have sufficient vestibular depth, sometimes it's easier for me to do a free gingival graft post-implant placement because now I have healing abutments that I can suture around. It's easier for me to immobilize my free gingival graft as opposed to doing a soft tissue graft where there's nothing really to suture to. So again, that's a decision that you make. Good vestibular depth, you don't have to do a vestibuloplasty, place your implants, go back in and do your free gingival graft. Narrow vestibular depth, do the free gingival graft first and the vestibuloplasty, then do your grafting and implant placement the hardest you can. For example, when we have a bone defect, we also have a tissue defect, and this is called a roll flat, where we can use, if we're doing an implant placement or implant recovery, instead of making a crustal incision, we can make it more on the palatal. We'll de-epithelialize the top of this flap. We'll open it from the palatal. And after we do our implant placement, we will literally roll the inside of that inside the flap and then close it. It's like doing a subepithelial connective tissue graft without having to harvest it from the palate. We take it from the site. Okay, that's what it looks like before. That's what it looks like after the lower tissue pushed out right here. It's no longer a soft tissue defect here. We can do this with alloderm. We can do it with a tissue bank skin graft. And there's two types that you can get. There's the alloderm, the regular alloderm, and there's alloderm GBR. The alloderm GBR is for sites where you're not going to get complete closure of your flap. The regular alloderm, you must have almost complete closure, otherwise it turns out kind of funky. I'm going to skip this video. I'm just going to show you this this graft. And again, the decision whether or not to take a palatal donor site tissue is going to depend on the depth of your palate. Because the normal palate is going to look like this, where your greater and lesser palatine arteries are going to be here away from the area because you're going to take your graft from here. But in a very, very shallow palate, those vessels are going to be very close to the area where you need to harvest this. And that's a problem. In a case like this, I will not harvest it from palate. I will go to a tissue bank material, allograft. Papilla regeneration using pedicle flaps. Yes.
If we're not able to close the flap, if the flap doesn't come in, there is a lot of tension. Can we use
Is that the reason, or you just create a large volume for bone graft?
if there is a large volume of bone graft? Is it okay if we use alloderm or
Alloderm GBR, not the regular alloderm, yes.
So, and if it's exposed, there's no problem.
No problem. But hydrate, you know the name Pat Allen? Any of the periodontists here know the name Pat Allen? Very famous periodontist from the United States, probably the world's best soft tissue guy around implants. He uses alloderm and he uses PRP in his alloderm. I use PRF, but it's the same concept, adding growth factors to it. Instead of hydrating with saline, hydrate it with polymers. Papilla regeneration with flaps. This is called the Palachi flap. Anyone here know that term? Where instead of making a crustal incision to expose our implants, we'll make it more on the lingual and palatal side. We will extend that flap to the facial. Then we'll take a little bit of a cut here, a little bit of a cut here, and then rotate that tissue to go into proximally. That's for people who don't use PRF. If you use PRF, that's what it looks like. You use PRF, you can do this instead. You can take a PRF membrane, open up your flap, and you actually put your PRF membrane around the healing abutments. And that will cover the interproximal where now you can't close your tissue because you've opened it and placed a final abutment. By doing this, we're covering the bone interproximally where the tissue won't close, and within days, that epithelium has covered that completely. Without having to remove anything, just tuck it underneath the flaps. But that's as close as you're going to get your flap now, interproximally. So this PRF will now cover this. We'll place at least a couple of membranes there. That's it, and it feels beautiful.
No need any rotation, just normal incision.
That's it. Vascularized interpositional flaps. These are great if you have huge defects. More of the run-of-the-mill side, where you're missing not just bone, but a lot of critical soft tissue. And here's an example of that. These are some of the worst cases that you can do. The patient's already unhappy, and they went through the process, they had implants placed, they had restorations placed, and now they're faced with a defect like this. So you're not looking just at a hard tissue defect, you're looking at a major soft tissue defect. And I've tried to do this in every manner you can imagine, and until we started using rotated pedicle flaps, or VIP flaps, which is a vascular interpositional flap. We didn't have much success. Look at that defect right now. What we do here is going to debride this. We're just going to open the flap around its margins. We're going to put a bone graft in. We're going to put a collagen membrane over the bone graft, completely tucking underneath the margins. But I can't rely, see how far that tissue is from here and here? I cannot rely on that tissue to epithelialize over the top before that thing opens up. It's not going to work. So in this case, we have to have some extra help. We're going to do a palatal incision right here. We're going to open this up, and we're going to physically rotate that tissue from the inside and cover that collagen membrane and suture in place.
This is from the palate.
From the palate. But it's still connected at this space right here. We've taken it, we've split thickness inside, we've pulled this underneath and rotated this over the facial bed. That's what it looks like with the bone graft.